Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. It's Monday, June 2nd. We're here at ASCO 2025 in Chicago. I'm Dr. Ali Khan Lalani, joined by my co-host, Dr. Chris Wallis. Chris, how are you doing, man? How are you feeling with
great.
Chicago?
It's been a good weekend, busy weekend, and really excited to get into the data.
Yeah, we're going to start with RCC, and in advance, folks, we do have sessions on bladder and prostate, so I encourage you to listen to that. But let's kick it off with kidney cancer. Break this down a little bit into the peri-op, which for now for kidney is still the adjuvant story, and then we'll get into a little bit of the first line and then what we do after. So Chris, the KEYNOTE-564 data, which we've seen before and is approved in many parts around the world, we had 5-year follow-up data from that. Maybe take us through that and then let us know if from a uro-oncology perspective, if that changed or informed any practice pattern for yourself.
Yeah, I think it's obviously interesting, great data. This probably fits in the category of the theme for the meeting, which is a little bit of something old, a little bit of something new. This is the something old, I would argue. So just as a reiteration, KEYNOTE-564 is a peri-op trial, so intermediate high, and M1 NED patients following nephrectomy in the first 12 weeks. Got to evaluate them, make sure they're not metastatic, and then they're randomized to either get observation, which was our current standard of care at the time the trial was designed, or to get adjuvant pembrolizumab for about a year, 17 cycles. And so the readouts have come, fast and furious. I think this is maybe the third or fourth report of this trial now. And so now we're out to, a median follow-up, 69 and a half months, almost 70 months. The DFS has obviously been reported, so it's not really the focus here. But we see, sustained and really robust improvements in DFS. So the hazard ratio here, 0.71, roughly a 30% reduction in the risk of disease recurrence or mortality. And when we think about absolute benefits, which is maybe, easier for patient counseling, depends on which time frame you look at, right? Our prior reports around 48 months were giving us something in the range of 8 to 10%. We're looking now out to 72 months even at this report, which is, 6 years. We're talking 58.5 versus 48.7. I think that's a difference that's meaningful to our patients. I was talking to some of our other med-onc friends who treat other solid tumors, and a 5+% benefit in absolute terms in the adjuvant setting is something that's, pretty remarkable across other disease sites. And I think warrants our attention. But, as the, maybe therapeutic nihilists that GU oncology people are, we always want to go not just for DFS, we want to think about OS. And so obviously we saw OS benefit to this regime presented at GU ASCO previously. But here we have an update. Hazard ratio looks good. And sometimes we see a bit of hazard ratio creep. We see them drift up as, the data matures. But here we have a really preserved benefit, a hazard ratio of 0.66, 35% relative reduction in the chance of mortality. And the absolute difference here is actually even maybe slightly larger, 86.1% versus 79.4. We're talking greater than a 5% absolute survival benefit at 6 years. Yeah. And I think that's really meaningful. It's not that this, survival doesn't come at a cost, and we could talk about, toxicities, and certainly we've talked at that in length in prior episodes. But I think, with this prolonged follow-up, we really see that this is a regime and this is a treatment strategy that does improve outcomes for our patients. And, OS takes into account that morbidity of treatment to some degree, right? These patients are still benefiting in spite of maybe some of the burden of therapy that comes with this approach.
Yeah, and I think the big thing, as you mentioned, right, we now have adjuvant therapy with a sustained DFS, OS benefit. You drop that data into other solid tumors, there would be significant uptake. One of the concerns, apart from the whole thought process that other trials with cousin medications have all been uniformly negative, there was a huge focus on subsequent therapies. It's still been presented, at least, we're fresh off of seeing this data. Still line items by systemic therapy for those who had a recurrence, systemic and surgery or radiation therapy only, all look about well balanced. the folks who had surgery or radiation therapy only on the pembrolizumab arm maybe proportionally a little bit higher, which you'd kind of like to see if you're giving adjuvant therapy, then if there's recurrence, you'd like to deal with that locally. The folks who had no subsequent therapy probably balanced, but that might have not been because they were withheld from therapy. It might have just been that they were observed or they haven't needed any.
Surveillance of low volume lung disease or something like that.
Which I think we've been doing for a long time. So, when we look at those who got systemic therapy, the pembrolizumab arm, as you'd expect, would have a good use of VEGF TKI. The PD-L1 use in the placebo arm was higher, So those who had a recurrence was N of 226. Of those, 109 got anti-PD-L1 therapy. And so, some people will argue that it should have been higher, but even on crossover design trials, it's not 100% that people get systemic treatment. So from a uro-oncologist, you and I have talked off camera about how this affects your practice and mine, but maybe just did that change anything? And more importantly, in the sandboxes in which you work, nationally, globally, what do you think this will do for the urology community?
Yeah, so I think it's interesting. In this space, I'm not always, but in this space, I was a relatively early adopter. And so I've adopted this approach for my patients, probably 2.5 years ago, maybe more now. We think when approval, I think was August 2022. So, this is something for me, the data is more reinforcing than changing. It tells me that we're doing the right thing, I think, by our patients. I think as you alluded to, some of the naysayers worry about subsequent therapies. And certainly I had my concerns early on about undertreatment of the N1 NED subset. We're not really seeing that bear out. And I think, as the longer follow-up plays out, that's the kind of thing you would start to worry about, is those bad actors emerging, and we're not seeing it. So I think for me, it reinforces, it doesn't change my practice, but it strengthens it. I think, in our community, we really need to think seriously about the fact that we are having discussions about whether we should be withholding agents with proven survival benefit. So my take is, for a urologist, that I don't think we're smart enough to make that call, which is to say, we need to initiate the referral.
Right.
The patient deserves an opportunity to talk to the medical oncologist about that. Not every patient needs to be on adjuvant therapy, and patients will make risk-benefit trade-off discussions or decisions in their discussions with the medical oncologist. But I don't think there's any subsets that emerge in the course of digging into this data as it matures that tell us it's clear that urologists should avoid adjuvant therapy in a subset of patients and not initiate the referral. So for me, the message for urologists, I think, is we need to send and let patients, medical oncologists talk about the survival benefits and weighing that off against the toxicity that it comes with.
Yeah, and I think, in fairness, it would be nice to see some of the timeline of use of therapy. Like, I would like to know, ideally from a trial that has good case report forms, in general, the timeline of the systemic treatment. We have, at least some countries like Canada, have the use of immunotherapy if patients have completed adjuvant, have not recurred within 6 months of completion, the clock resets. So if that's the case, I think the community is asking for data to show when IO therapy was used, what was that median time or what was the usual time? Because we all think at an individual level, if a patient recurs, we could look at SBRT, we could look at repeat surgery, we could look at systemic therapy, but all of those choices might be informed by when. I think the gaps still remain. What do we do if folks recur on adjuvant? I think there's trials to come on that. I do think if subcutaneous immunotherapy is coming, how will that inform practice, if at all? So, I must say I would have liked to have seen more enthusiasm and granularity. I think this time around, I think you and I talked about that, but
subsequent therapy data in particular, I think we could do more. The idea of what first line metastatic treatment was, rather than this whole idea of what did they get at any point, would maybe help us assuage some concerns that there's under treatment in the control arm that's maybe exaggerating benefit. My gestalt is that that's probably not the case, but we don't have the granularity of the data to make that argument really convincingly.
Yeah, and especially because there's other cousin trials that are negative. It is going to need, we have to look under the hood a bit more. And that's okay, because if we had a bunch of positive trials with the same context, we'd be having different conversations about how do you pick between each one.
For sure.
Yeah.
For sure. So, I mean, maybe the transition there, we're talking already about how we capture the adjuvant failures is what are we doing about the first-line metastatic space? Again, a little bit of something old, something new. Unfortunately, nothing blue in this conversation, but walk us through maybe the old, which would be the updates on CheckMate 214.
Yeah, I mean, look, the punchline is doublets are still here. We've talked previously about triplet studies, which thus far are not positive. So we now have, believe it or not, a median OS follow-up of 9 years in a first-line kidney cancer setting with the CheckMate 214 trial. So Nivo, Ipi, followed by maintenance Nivo against sunitinib, a trial we've known for a long time. So focused on intermediate poor risk, OS hazard ratio relatively preserved. Out of all the doublet trials, the IO study has had a preserved hazard ratio of 0.69. And obviously those who respond do very, very well. Median duration of response of over 80 months is incredible. What I found interesting was a favorable risk. So look, all the IO TKIs were designed by intention to treat and approved. Okay. Interestingly, none of those good risk subset of patients have had an improved OS with IO TKI despite response and PFS being better. So we look at CheckMate 214, first study designed to look at intermediate poor risk, though all risk groups were included. And now we look at their favorable risk. So again, with the fact that curves cross, we can talk about that violating cost proportional hazards. Nevertheless, the medians are different by about 11 months with Nivo, Ipi, and good risk patients. PFS may not be the right story to judge that. A duration of response still really good. One would wonder if this was an ITT, evaluated and approved combination, would we be able to use IO in good risk patients conceptually? If you're good risk, few lung nodules, few lymph nodes, could I extinguish that with Nivo, Ipi, even if you're good risk? I would think so. So, but nevertheless, because the ITT OS was improved 52 months versus 38 with a hazard ratio of 0.71. And so I think, all the point estimates were beneficial. So I think really, we've really seen that all of the benefits seen in CheckMate 214 obviously preserved with intermediate poor risk. Nice to see long follow-up.
Absolutely.
And I think kind of from that, what we then wanted to also see is updates from PDIGREE. And really, just in fairness, this was largely this was a step 1 and step 2. So for those, just to remind everyone, the PDIGREE trial was looking at Nivo, Ipi as a step 1 induction, and then an adapted response at 3-month mark. So having, if CR, you got Nivo. If you progressed, you got Cabo. And if you were kind of non-CR, non-PD, you got randomized. And so all we really saw from this was the step 1, trying to see that patients who entered, 1,100 patients for the ITT, the discontinued subset of 364 patients, what were they like, and then who moved on to step 2. Not much we really took away up front. I think it was mostly just to show where things are at, but it's a huge effort, right?
Yeah.
This is a cooperative group study. And I think, interestingly, I think we talked about this, right? That response of CRs in those first 3 months looked a little lower than what you did.
9%. What would you expect out of 214?
Well, I would expect somewhere between the 9 to 11%, but if you look at the CR arm, there was 9 patients.
9 patients.
Right. And the registration to step 2 was 747. So, I think that this is just really not as high as you'd expect. And you wonder how much of this came from those patients who maybe could have been evaluated a little bit later. But
do you think it's a 3-month cutoff, or is it the fact that we're going from centers of excellence doing the trials? PDIGREE, to its credit, is a very pragmatic approach. Half of patients treated in community centers as opposed to academic centers. Is this what we can expect as Nivo, Ipi is just more widely diffused, or is it just too early to tell at 3 months to give the doublet IO chance to actually regress disease?
Look, there's no question that CRs migrated, so to speak, when you first saw 214, that the follow-ups, when you look beyond 3 months, your CR rates did change. So I think that's a reasonable assumption to say, but it is very low. One wonders how much of that is the real world and really the utility of these drugs, countered by the fact that we should have had really good experience with nivo-ipi by this point. So I won't make too many judgments on that data, but I do think it was nice to see that step 1 patient population, and we look forward to the final data.
Absolutely. So, we've talked a lot about IO and maybe some IO TKI combos in RCC. The general principle being you want more mechanisms of action, right? You want more ways to attack the tumor. So we saw a little bit of data with some novel TKI approaches. You want to talk a little bit about Zanza?
Yeah, so zanzalintinib or XL092 is a new TKI coming into trials, and hopefully the aim is to market. So just a quick refresh. It's felt to be a shorter half-life drug, which when you think about utility of a drug, dealing with side effects, how it affects patients, the short half-life can be appealing. It inhibits VEGF receptor, MET, some TAM kinases, and it was evaluated in prior, the Stellar umbrella of trials. And so what we saw was a Stellar 02 first-line clear cell RCC expansion cohort. So this was non-randomized, but sequentially assigned patients to get zanzalintinib at 100 milligrams daily and nivolumab at the Q4 weekly dosing. And another arm, so again, not randomized, but Zanza plus Nivo, and then also looking at relatlimab, which is a LAG-3 inhibitor, and trying to look at the fixed dose combination. And so, really punchline for that was that, and again, in non-randomized data, but having N of about 40 in each arm responses. Interestingly, with the Nivo Zanza group was about 63%. 40% in the Nivo-Rela Zanza group. But what was really, I think, important is that those who had a prior nephrectomy was higher in the Nivo Zanza group. So if you have a prior nephrectomy, the chance of response is higher. And interesting, those with sarcomatoid features, which we think matters to immunotherapy, was also higher in the doublet arm. So on that basis, ultimately, there'll be more to come. But, it is looking at Zanza and immune checkpoint inhibitors in solid tumors. There's a phase 3 trial of the doublet versus sunitinib in metastatic non-clear cell RCC. We can debate a bit about, a sunitinib control arm in a non-clear cell population, realizing this is now no longer just an umbrella term. It's variant histologies. It's molecularly driven. So we'll have to see where that goes. And I think this drug will be evaluated in a kind of post-adjuvant IO, post-IO setting. So more to come, but it was interesting to see a little bit of a hint of what could be other so-called first-line advanced disease studies.
Absolutely. And we think, back to the idea we were thinking about with PDIGREE, with, that subset of patients not responding well to their upfront therapy. We saw a little bit of Canadian data here, which is nice. IMDC work on primary progressive disease.
Yeah, I think it's a shout out to the Canadian Kidney Cancer Information System, which feeds into IMDC, which is obviously an extremely important repository of real world data. So the IMDC data, just a shout out to the group there that actually evaluated what happens to primary refractory patients. So got a first line doublet, unfortunately had a PD as best response. And they looked at all the agents used thereafter. And unsurprisingly, and I think it was important to show in the real world, the responses and the subsequent PFS of having cabo as your second line option, whether it's after IO-TKI or even after IO-IO. And I think especially for patients who get nivo-ipi and have primary PD, which is not what we're looking for, I want a key TKI next. So I think for countries that have access to cabo after nivo-ipi, it's super important. And I think for those that don't, because the approval did require initially a TKI prior to getting cabo, I think it further just real world data reinforces we should be able to use that drug after your doublet. There are efforts in some countries that haven't had access now have, for example, Health Canada approval, but we're looking at reimbursement. And I think, as you point out, that's really what keeps you up at night is the primary PD to a very good upfront doublet.
Absolutely. So you want to bring in more tools, more options. We've known about the sort of hypoxia pathway as being a key driver in clear cell renal cell carcinoma for decades now, and only in the last 5 years or so, maybe a little longer, have we been able to actually act on that in a clinically meaningful way. So maybe give us just a quick refresher on VHL, maybe the HIF pathway in clear cell RCC, and then we have a few abstracts here on targeting of that pathway.
Yeah, big picture for kidney cancer, VHL alteration is important. if you inherit it in every cell of your body, that's so-called VHL disease. So that's an alteration where you'd think that a treatment that goes against HIF2 alpha would have the biggest benefit. But even in non-inherited VHL issues, we think we acquire VHL alteration. And usually what VHL would do is target HIF2 alpha for proteasomal degradation, just, for hiking Mount Everest or in normoxic situations, it has its mechanism. So when you alter VHL, HIF2 alpha isn't degraded. It goes to the nucleus and makes all these VEGF factors, which go to endothelial cells and cause cancer growth, amongst many other things, cell growth cycle issues, EMT, metastasis, metabolism. But the key thing is that now having a drug that is a HIF2 alpha blocker that can then, interfere in some way with HIF1 alpha, HIF1 beta interaction with HIF2 alpha. So if you block the HIF2 alpha, you then lead to, hopefully less accumulation of these bad and targets. And so having a drug like that already, we've discussed through LIGHTSPARK-005, a drug like belzutifan, which went against everolimus, improved the hazard ratio for PFS, not the median, improved response, not overall survival, approved in the US, supported in Europe in a third and fourth line setting, and now having been reviewed in Canada and already having an access program, so will likely be in the water in a North American setting as well. It's nice to see that data, but this isn't the only drug. And so what we actually saw here at ASCO 2025 was results from the expansion cohort of a phase 1 study with a novel HIF2 alpha inhibitor. So this is casdatifan or Cas. Tony Schwery presented how this HIF2 alpha blocker performed. The questions was, how is this really different? Do we need a me-too? I mean, the feeling is that, this mean half-life is approximately 24 hours, that there's a similar level of EPO suppression at even a 20 milligram dose as there would be at belzutifan 120. So again, need to play that out. Casdatifan 100 was identified as a dose moving forward. And again, evaluated this in a situation of a post-IO setting and, really showing that already casdatifan plus cabozantinib, which is a drug we've known for a long time in a pretreated setting, had a response rate of about, 46%, not really going to be CRs, but a primary PD rate of about 4%. So again, it's early expansion. I think the big takeaway from this is that there could be another HIF2 alpha drug to come, and it's going to be combined in a phase 3 trial of PEAK-1 study, which again, very briefly, is going to take those who with advanced disease, had immunotherapy, randomized to cabozantinib with a placebo or cabozantinib with casdatifan, primary endpoint of PFS, a 2-to-1 randomization. So again, I think it was more of a tease of what's to come. So as folks get used to using the belzutifan in the real world setting, oh, by the way, there's going to be other drugs. And of course, belzutifan is hoping to get readout with lenvatinib versus cabo in the LIGHTSPARK-011 trial. And now we have the PEAK-1, again, cabo versus cabo plus casdatifan. So as soon as we get used to it as a monotherapy, which again, I don't think rescues every patient, right? It's a very important option, but I think now moving it in combination, we want to see it pack a better punch.
Absolutely. And, maybe you alluded to it a little bit before, but let's go back to the idea of VHL disease. And so we got, I think, maybe going to be the final readout at 5 years of LIGHTSPARK-004.
Yeah. So and very, very quickly, this was, the 5-year data of belzutifan's activity in VHL, disease-related RCC, CNS hemangioblastomas, and PNETs. And really the takeaway here is that the 120 milligram dose, these patients had a response rate of about 70%. And they were nicely able to show the responses in the kidney, which from a uro-oncology perspective, these patients otherwise would have been, perpetually kind of having RCC resections, right? Not advanced disease, but if you can obviate that with responses. And then again, we saw responses in the CNS lesions, in the PNET lesion. So, again, this to me, for those who have inherited this alteration in every cell of their body and have this disease, this has been a really nicely targeted and molecularly rational drug.
And this is, again, not a patient population that's huge, I think, in your clinic or in mine, but really just a flag to think about those. You get really early diagnosis kidney cancer patients, multifocal bilateral disease. Maybe there's some of the other syndromal features, even if it's not known in the family history. These are good patients to send off to the genetics clinics, because we know as the urologist, doing the third or fourth partial nephrectomy on each given side is not all that much fun. And so if we can give an oral, fairly well-tolerated agent and obviate the need for those repeated operations, it's certainly in the patient's best interest.
Yeah, these are young patients. This is a generally well-tolerated drug. We can deal with the anemia, whether it's holds, reductions, transfusions, or in some places just a dose of EPO, which can last for quite some time. I mean, these are this is part of that art of medicine and caring for them. So I agree with you. It's not that surgical requirements when needed aren't important. It's just that, we have a drug that works, and I think we're seeing this in clinic.
Absolutely. So we're coming to the end. Do you want to go through any potpourri, anything interesting in the CAR T world or biomarkers the world needs to know about?
I mean, I would say, look, off-the-shelf CAR T, we saw some data for this. It's pretty encouraging. I think it's early. Many of our academic centers have docs who use CAR T largely for blood cancers. But, interesting to see this build upon prior CAR T evaluation in kidney cancer. So kind of follow this space. Needs to be evaluated in a larger sample size. And of course, as always, it's going to be ethical considerations for patients with long-term side effects, and then obviously making sure it provides benefit in what situation and that it's feasible. Very quickly, we had a great biomarker section. Personally, I really enjoyed that and want to watch it again. I encourage all of you to. It's biomarkers in kidney cancer. Lots of great data in perioperative spaces using matched samples from resected and recurrent. So great work. Axel Becks, Monty Powell, and the whole teams in those respective studies. David Braun showed some great data with tumor microenvironment features with Nivo-Cabo. And then we saw maybe a blood marker that can portend or speak to the microbiome health in patients as we look for more and more gut microbial intervention type studies. I think the big take home is that we're realizing if there's T regs or T cells that are more inhibitory, that seems to portend worse outcomes. Can that be manipulated? I think the bottom line is we don't have a eureka biomarker, although I would say KIM-1 looks to be rising. It looks to be rising to the top here to say, here's a blood test that our nephrology and even cardiology colleagues, non-cancer, have been doing for a long time. It's an available blood marker. It looks to be relevant to say something about either minimal residual disease or perhaps microscopic cancer burden in the blood. So maybe moving forward with KIM-1, perhaps refining perioperative approaches might be nice. So I think that's one biomarker to keep in mind. And then all of these forays, right, looking at machine learning, DNA, RNA, proteomics, it's important because it's going to help us understand things better, and maybe one will rise where we do a randomized study in it, or maybe just like sarcomatoid features, we didn't need a separate randomized trial. We just kind of feel like that's available. It's pathologic. It's on our report, and that might inform how we pick treatment. So I encourage all the biomarker work we can, even though it's an elusive holy grail in kidney cancer. It's been really exciting, and I encourage folks to listen to that.
Absolutely. So as we wrap up, I want to thank you all for joining in the highlights of kidney cancer here at ASCO 2025. Stay tuned for the 2 subsequent episodes looking at bladder cancer and prostate cancer. On behalf of my co-host, Ali Khan Lalani, I'm Chris Wallace. Thanks so much for joining us on The View and GU.